exposure, exposure, exposure. So that's why I dressed down today and wore short sleeve, because I don't need a model today. I can just do the exam on myself, and I might use Adam to do a couple of other things. But the exposure for that extremity examination should still come all the way up from the shoulder on down, because the shoulder, again, is linked to the elbow, linked to the hand, linked to the wrist. You want to be able to observe how your athlete moves as you test them out. Okay, and also just coming into the room. Something I may not have mentioned last time is just when you see the athlete come off the field, or when you see the athlete for the first time in the training room or something like that, you want to notice how that person comes into the room in terms of any injury that they're looking at, just to get an idea whether they're limping or whether they're kind of guarding behavior, in which they're kind of holding their arm, or whether they walk in quite fluidly and you don't really notice anything. Maybe their fist is clenched. You know, obviously if they have any bandages on it that they came over, if they were away and came back with some bandages on it, obvious stuff like that. And so beyond that, you're then just going to look just like before. You're going to go ahead and inspect and look and see what you notice about their arm, their hand, anything like that, whether there's any swelling, whether there's any injuries to the skin, which are going to lead you in the right direction. Because again, you want to get down a system, a pattern of examination, so that you don't miss anything and so that it goes very smoothly and you're not kind of bouncing all over the place. Because while you're doing this, you're synthesizing in your head what your diagnosis is going to be, so that you can pass that along to your colleagues and the physicians. And so in terms of inspection, of course, the skin is number one. It's the easiest thing to see, and also how the posture of the hand is. If we all just put our hands down by our side, normal posture of the hands is with a little bit of a curve. There's an arch type phenomenon to the hand. Okay, there's an arch in this direction where the fingers are arched, and then in this direction, in this plane right here, there's two arches here across your knuckles, your metacarpal phalangeal joints, and then through the carpal row, which is your wrist bones, your smaller wrist bones down here, before you actually get into the hand. Just to back up for a second, for purposes of discussion, the hand begins right about here, where it's the base of your metacarpal bones and down, to include the fingers. That's considered the hand. From there to your ulna and your radius bone, and then there's small bones, the carpal bones in here, that's the wrist joint. Okay, so you have wrist, and then from the metacarpal bases, the most part closest to the elbow of your metacarpal and down, that's hand. So that's hand and wrist. Then of course you have forearm up to elbow, and we know everything else beyond that. That's just some semantics. So back to, again, resting posture. It's because your flexor tendons, the tendons that make your fingers flex, they're kind of a little bit stronger, a little bit more powerful than the extensor. So you want to look at the individual and make sure that individuals that come in with their hands out straight like this, not likely to be seen by you all that much, except that would be like a guarding posture, like it would hurt somewhere. That's why they have that. But it's like in older people, when they get old and their muscles start to waste, people will have a hand that kind of gets a little bit flatter. And so that's just something to notice about the posture of the hand and the wrist. Same thing for the wrist. Are they kind of holding it down like this? In which case they may have a degree of a palsy, which doesn't happen a lot, but sometimes can happen. In football or other contact sports, if they were to get a really bad stinger or some sort of injury to their brachial plexus, they could have a cocked position of their wrist like this, and that would be indicative of a palsy of one of the nerve branches or one of the roots of the brachial plexus. That's called actually a waiter's tip kind of palsy, but that's just something to look at as an example. And then how, during your discussion of your history, how they use the hand, whether they are whether they are gesturing with it or not to kind of describe things, or are they really guarding against using it for any purpose whatsoever, so that you can get an idea of what might be bothering them. Whether they're guarding fully, maybe that's all, doesn't really help too much there, or whether they're just kind of like keeping their hands stiff, but they're moving their elbow around. And you also want to pay attention to that too, because there are less likely in the athlete population, but sometimes you might get those student athletes who on a team sport aren't really getting all the time that they think they are, and they're starting to doubt themselves, and they're starting to doubt whether they're not, and so, they might be kind of, for lack of a better term, faking it a little bit. And so you'd want to see that as you examine them and as you talk to them, like if they're kind of moving around talking to you about how things are going, and then when you go to examine them, they're like, that hurts so bad, oh, that hurts so bad. Okay, they're kind of faking it a little bit there, so you want to just keep an eye on that. After you get through that, as they come through the door, and just look at them and check them out that way, and you get down your history and everything like that, and then you're going to focus your exam. So part of the physical exam is to start with how they, so you've already inspected everything like that, you're looking at the skin, you're looking for any areas that might be swollen or edematous or bruised or anything like that. Then you're going to focus on your exam. Quite easy, it's very simple. Start with motion, okay? Start with how they can move their hands, how they can move their wrists, elbows, shoulders, etc. It's very basic stuff. Generally, you can do it any way you want. This is just the way that I do it. So I'm going to want to look at how they move their wrists. So I'll have them bring their arms straight up in front of them at a 90-degree angle up here. And I'll start with the wrist just because I'm here now. And you just want them to bring their wrist up like they're trying to push against the wall or do a push-up. And generally, it should be about 70 to 90 degrees of what's called extension. That's extension of the wrist. And then down this way, they can go down to about 70 to 90 degrees, mostly 70 to 80 degrees of wrist flexion. You have them bring their arm back to the side for you there because you want to test forearm and wrist and elbow pronosupination. Pronation being palm down, supination being palm up. What's called the neutral position, the way that it's graded or the way that it's described is that a neutral position is with the thumbs straight up in the air, and so you'd want to see if they can fully supinate to a full palm up position or fully pronate down to a full down position like that. Elbow, back up to the elbow for a second. It's very simple. Have them come out to the side so that you can look at it. For extension, some people will hyperextend. Can anybody hyperextend? Most young ladies can hyperextend to some degree, sometimes freakishly so. Most men just kind of go out nice and straight. It's okay if they're a little bit tight. Sometimes you'll have guys, bigger guys, football players and basketball players who have bigger biceps, bigger muscles. They will not fully extend all the way up. That's not a problem necessarily for them. That just means that they have some pretty tight elbow flexors. They can be stretched out, but they don't really need it. Functional range of motion for the elbow is about 30 degrees up to 110, 120 degrees. That's perfectly fine. Some people lose that as a result of injury. That's okay. They don't have to come all the way out straight. It makes it difficult to do pressing maneuvers and stuff like that, but when you can't go all the way out straight, they learn to compensate for that. The normal flexion is usually up to about 140, 150 degrees depending on the individual. The reason for 30 to 130 is to be able to take care of yourself. You can't really get back there if your arms out straight. You can't, if your arms bent, you can't get down there and take care of yourself. And that's really what it comes down to, pretty basic stuff. So that's basic elbow. Elbow flexes, extends, and then pronosupinates. That's it. That's all you got there for the elbow. It's very important, but that's all it does. Not quite like the shoulder. Not as involved as the shoulder. You got wrist up, wrist down. Wrist also deviates, what's called deviation. Okay, and that's bending to the side. More ulnar deviation, which is to the ulnar bone. Okay, much more than that. Usually about 40 sometimes even more in some looser people. Versus radial deviation, which is much less radial deviation. And that's towards your thumb side. And that sometimes can only be about 10 degrees, sometimes as many as 30 degrees, but it's not that much. So that's wrist up, down, over. Very simple. Onto the thumb extends, thumbs up. That is thumb extension. Okay, the thumb flexes, in which it bends down. And now we're doing this all through what's called our metacarpophalangeal joint, which is the larger joint at the base of your digits, at the base of your thumb and fingers. And so that's up and down. And then the thumb also does something which is called opposing, and it opposes with the small finger. That's called opposition. They go towards each other and they oppose each other. Part of that mechanism is also what's called, down here you'll see in the area of your palm called the thenar, T-H-E-N-A-R, eminence. That is what's called adduction, for getting closer, AD, for adding to, or getting closer to the rest of the hand, versus coming away. And when you look at your hands like this, and you bring your thumb out like that, part of that is flexion, but extension, but also part of that is what's called abduction, or taking away, or moving away from the hand. My fingers as well are now in an abducted posture in which they can spread away apart. Some people might be a little webbed. Some people might have an issue with the muscles inside the small muscles of the hand in which they can't bring them apart that much, or they might shake a little bit while they do that. That might be indicative of an injury to the hand or an injury to the small nerves or one of the bigger nerves that brings power there. We'll go over what nerves those are for each individual function in a minute. And then fingers can obviously extend out nice and straight, and in a lot of people they hyperextend. Okay, they hyperextend, tend to as much as 30 degrees. Pedro Martinez, a famous baseball player, I've seen him a couple of times and examined him a couple of times, and he hyperextends like this. It's a little absurd. That's why he was able to throw a fastball like he did. And then there's flexion. And then we can flex down halfway, or we can flex down fully into a fist. And then you want to look at their fist end on like this. In a resting posture, the knuckles line up nice straight line. You look at your own fist, and then you clench the fist. You'll notice that your small finger and your ring finger, they drop down at the side in a clenched fist. That's a normal posture. The reason for that is that the bones on the outside part of your hand are much looser. You can jog them up and down like that. They don't have stout connections. The two inside ones are much, much, much stronger, which is why when you see people who get breaks, or if anybody's ever punched anything and they now have a break over here on either their small finger or their ring finger, was that you? Does that guy get one? Those people don't know how to punch, because you're not supposed to roundhouse and punch with those smaller bones because they're loose and they don't. That's why it's typically called a boxer's fracture, but that's actually not accurate. It's actually a fighter's fracture. Boxers know how to punch. And when boxers break their hands when they punch, if you ever see them in a match and you see somebody start to favor their hand, what they've broken is they've actually broken the second or the third metacarpal down here around the base. Because when they punch straight fisted on, because you know that the most impact, the biggest impact, the biggest force of delivery is through your long finger and through your index finger and metacarpal, not through here. The rest of us all punch like this, because that's what they do in the movies. So, all right, so that's motion in the hand, wrist, elbow, and forearm for now. Any questions about motion? This one, as you can see, moves along a lot faster than the shoulder. It's not as complicated there. All right, so after we've done that, what I like to do then is I like to go and I like to test the sensation in the hands and in the forearm, because before I start to provoke the patient or provoke the student athlete and make them then guard against it, or sometimes you can irritate the nerves to the point where they start to have some sensory abnormalities. And so this is just very basic sensory exam, in which you just basically, you want to touch both sides, both the affected and the unaffected side, because you want the athlete to be able to compare if it's a difference on one side or the other. Okay? And so generally the distribution in the arm is like this, and in the whole body is that you have these things that are called dermatomes. You've heard about that? Yes, right? So dermatomes, in which there's numbers for the different nerves that come out of your neck, and then they kind of wrap around the arm like that. So we start here on the outside, and on the outside here, we're looking at about C5, and it's going to come all the way across and back up to here to get to T1. Now you don't need to tell the physician or anything like that. You just need to kind of describe the location of the sensory change or the sensory disturbance. It's quite easy. It's either on the outside of the forearm or the lateral forearm, on the medial forearm, or on the dorsum of the forearm, or on the volar aspect, front or back of the forearm. That's what you're talking about there. When you get down into the hand, we can talk about individual nerves, because most physicians will talk in that respect. Around the forearm, there's some smaller nerves that give the sensation around there, so it's easier, in my opinion, just to describe the four locations on the forearm in terms of your sensation. But when you get down to the hand, there's three nerves that provide sensation to the hand, and it's very, very easy, very basic. The ulnar nerve, which runs right behind your medial epicondyle of your elbow here, and everybody can palpate or feel their ulnar nerve back there, and you can roll over it, and you can push, and you can feel back there and stimulate it a little bit on yourself, and you might feel a little shock go down, or you might just be like, that's not fun, I don't want to do that anymore. That's a nerve, right there, right behind your medial epicondyle, right in front of your olecranon tip is where your ulnar nerve is. And people, sometimes golfers especially, can get some what's called cubital tunnel, or get some stretching of the nerve, which causes some local inflammation around there, and they can get some tenderness there and some sensation disturbances that go down the forearm here, all the way into your small and your ring fingers. And on the ring finger, it's very, very interesting. The ring finger is provided sensation by the ulnar nerve on this side here next to the small finger. But if you go over on the other side, it's a totally different nerve on the other side. And so on the other side there, they will, so some people who have a really bad ulnar nerve problem here and are completely densely lack sensation down here, they can't feel a thing on this side of the finger, but on this side of the finger they have normal sensation. So it's kind of interesting to see that. You don't want to see that in yourself, of course. And so for that nerve there, you can stimulate that nerve by just kind of tapping on it a little bit. and that's called a Tunnel's maneuver. Anytime you tap anywhere around a nerve to